But first, allow us to say hello to the best in the business, Dr. Kevin Most.
Good morning.
Hey, guys. How you doing?
Great.
And we're fine, Doc, and I know that you were worried. I got my colonoscopy test results back yesterday. One polyp, benign.
Good.
Woo!
Good to hear. Good you
good
did
news.
that, too.
And
Yes.
I named that polyp after one of the people that fired me.
Yeah.
I'll allow all of them to guess if they made the cut. Dr. Kevin Most, Senior Vice President of Medical Affairs, Chief Medical Officer at Northwestern Medicine and Central DuPage Hospital. It's a great hospital. If you have to get sick there. Parkinson's disease. This is very encouraging news about figuring out if we're in trouble here, right?
Yeah, it is. It's kind of fascinating. And we've talked about a lot of illnesses and how we make the diagnosis once you have the symptoms. But wouldn't it be great if we could identify somebody prior to having the symptoms? So we talked about Alzheimer's and how are we going to do that. And now Parkinson's, this is a study that came out of Denmark recently that showed that looking in the back of the eye and actually doing a test called OCT may be able to identify individuals who are going to have Parkinson's up to 7 years prior to them having symptoms.
Wow.
So that is something that goes to the do I want to know, do I not want to know? Explain to people why they want to know.
Well, and that's, exactly. So why would I want to know? To slow progression? Is there things that you could do? Because there's no cure for Parkinson's.
Correct. Well, that we have treatments for Parkinson's, but there is no cure for Parkinson's. And one of the reasons there is no cure is because we really are still trying to figure out why this even occurs. So now that we can identify it early, it's going to allow us to try more different treatment modalities, try lifestyle modification, try other drugs. And it's fascinating that we can find this out that early. It also allows the individual to plan and to look for those early signs and symptoms and to make sure that we get treatment and that we start to talk about treatment options versus the shock of, oh, you have Parkinson's. Now, I do agree with you. Some people will go, oh, my gosh, I don't want to know. But if we're going to advance science, then we're going to need to know any way that we can identify an illness earlier to see what we can do to make changes and modifications to slow the progression of that illness.
So, Dr. Bose, let me ask you this. How early is the earliest we know that someone was diagnosed with Parkinson's? And then, even if you don't have family history of it, because I don't know that we know that it's genetic or familial, who can get this test? And should we all just get it? So if it's something we want to know?
Yeah, it's interesting that the test is available now. And this is this test called OCT, which is essentially a 3D scan of your eye. And we use it for many different reasons. We use it to monitor eye health. We use it to monitor some kinds of blood pressure issues and hypertension in the eye. So there's many reasons that we do it, and it's available now. Many of you, if you go to a fairly extensive eye clinic, they have the capability of doing it. And it's as we're starting to find tests that are used for more than one thing. So when you look at the doctor and he comes at you with that little flashlight in his hand, and he looks in the back of your eye, he's looking for the back of your eye to look for health, right? Health reasons. Do you have diabetic retinopathy? Do you have high blood pressure? Do you have issues like that and how it's affecting your eye? What this is going to allow us to do is potentially identify even more. Can we now identify MS earlier? And like you said, since there are no treatments or there are no cures, how are we going to start treating this more aggressively as we know that these changes are occurring?
All right. Now, there's another question that pops to me about this. As we get older and we can't remember where our car keys are, we see somebody we know and we can't pull their name. We all think we have dementia. And that's rarely the case. It's a group and a set of symptoms, in a progression before you even have to get checked. But that's where our minds go. Parkinson's, north of 60 again. What if you have a little shake in your hands? A little shake in your hands you didn't have before, that type of thing. Is that a concern?
Well, it should. It should be a concern if you have a tremor that's not there. Now, there are many, many different reasons for tremors. So certainly if you have a shake in your hand, if you have a tremor, if you start to see that your balance is off a little bit, that you're shuffling more with your gait, certainly having that seen by primary care or a neurologist is important, because early on there are many medications that can totally eliminate the symptoms of Parkinson's. And then as it progresses, those medications don't work as well, and then we have to look at other options, including, placements of electrodes into your brain that teaches your brain and does what happens with the chemicals in Parkinson's, and it corrects it. So if you look at Parkinson's and brain therapy. Google it. There's some amazing things that are going on right now.
But when you talk about tremor in that regard, it's tremor that doesn't necessarily go away, that it's fairly constant?
Well, correct. I mean, if you look at tremors, there's many, like I said, there's so many different reasons for tremors, and it's one that getting into your doctor and have them look at it. There's intention tremors, there's tremors that stop, and then there's others that continue and are almost continuous. So essential tremors, those are tremors that when we see with Parkinson's, and we're gonna find out more about them as we know more and get involved earlier.
A couple of questions online. You want to hit those texters?
I do, but I actually want to, while we're talking
You have
about
a tremor follow-up?
I do.
Parkinson's?
A brain follow-up, because you brought up, I don't remember this. I say, oh, my sponge is full. Should I be worried that I have dementia or I have Alzheimer's? You say that there's a new test that people can order to detect if they have Alzheimer's. I think that's a follow-up to a brain disease.
Yeah, this one could be a little bit more controversial. It'll be interesting to see how well it's accepted. This is a first, essentially, direct-to-consumer test, so you don't even need a doctor's order to get this test done. And this test is done by Quest Diagnostics, and if you Google Quest Diagnostics Alzheimer's test, it'll come up and say, tell me your zip code, and you put your zip code in there, and it will tell you where you can go to get your blood drawn to have this test done. And then the test is run, and it's the results that are sent to you either via secure portal or a doctor actually calls you on the phone and discusses the results. And what this is looking for in the blood is something called beta amyloid, which we've talked about numerous times. That beta amyloid builds these plaques in our brain that slows down the information highway for our brain, and that's why we have cognitive problems. The new medications are blocking that. Well, what this blood test is doing is looking at a ratio of how much beta amyloid you actually have in your blood. But we have to understand there's people with beta amyloid in their blood that don't have Alzheimer's. So it's a little controversial right now. It'll be interesting to see how it goes forward. $400 for the test.
Out of pocket.
Really
that's not an insurance paid thing, right?
Correct.
Right.
Correct. And it's really focused at individuals with, mild cognitive problems or with family history of Alzheimer's, and you want to know.
Well, Quest is a major company. Is there any reason to think this is a cash grab?
Well, it certainly is going to be a cash grab initially until the results get validated in a really good big study, and that's probably what they're trying to do, is get as many data points as they can to say, yes, here's the level that is really going to make sure that it's a false positive. Here's the level that we see is going to advance. And now you're going to have a lot of data points where it says how quickly does it advance. Because remember, when we talked recently in the past couple of weeks about Leqembi, that's a medication that we want to give to people early on in the illness. So identifying those people early on, this may be one of the ways that we're going to do it.
We've got a couple of textures on. Jane has those when we come back.
Yep.
And we'll talk a little RSV as well. So let's all clear our throat and listen to each other's chests. And we'll come back in a moment. If you're alone in your car, try to focus on the road. No one better communicating the language of medicine to those of us who don't understand it than Dr. Kevin Most. Listen to your doctor. I mean, do the hard work. Nobody's ever going to be a better advocate for you than you. Dr. Most, you've said that for years. But when you come in with your notes, and you should have notes, walk in with notes. Say, this is what I'm feeling, and listen to your doctor.
And bring an advocate with you if you need someone to listen.
100%. Somebody that can listen to what the doctor's saying. Because you're trying to process what you're hearing. Maybe you're not hearing all of it. That's a great idea.
And go and do some proactive medicine, get a foundation, get the baseline.
Jane and I are really good at this, Doc. Do we need you at all?
No, you probably don't. And Jane, you bring up a very good point about having an advocate there, because the patient is listening different to the physician than actually the advocate can be. Now, I'm sure, I haven't met your husband, but I'm sure he's a wonderful person. But what he hears may be totally different than what you hear and what the intent was for the doctor. So it is a really good idea for an advocate to be present, to listen, to say, no, that's not what he said, or that's not what he meant. So sometimes the patient is a little bit more nervous and a little bit more concerned and is not listening in the right frame of mind.
Yeah, taking the notes differently, and I found that a lot with my parents. By the way, Kurt is a great guy because he likes golf, just like you and Steve.
He's good.
Yeah, okay.
So he's okay. All right, texter questions.
Yeah, our buddy Terry is talking about ablation for atrial fibrillation. Now, his question is, and we know atrial fib is that irregular heartbeat. Is an ablation, will that solve the issue 100% because of the original medicines and the reset didn't hold?
Yeah, so for atrial fibrillation, there's different ways to treat for it. We can shock you out of it, and hopefully the electrical activity goes back to its normal and stays there. It sounds like it didn't with him. Mm-hmm. There's medications that we can give that sometimes will correct that. And then when those two don't happen, we end up going in and doing something called a maze procedure. And what that is we look at the entire electrical activity of the heart. And a very highly trained cardiologist then goes in and burns or freezes those electrical connections that are making the atrium fibrillate. Mm-hmm. So if they take that away, then it goes back to normal. So it's a procedure that can take many, many hours. Sometimes it's only a couple hours, but sometimes you're talking, 5, 6, 7, 8 hours for these procedures. But it can totally eliminate the chance of atrial fibrillation because that aberrant pathway, that electrical activity, now doesn't have a pathway to go because it's been ablated. So it's been either burned or frozen. It's been taken away so that it goes back to a normal electrical activity. Yep.
Our friend Tom, there's more to that?
Pretty invasive, but very good in the right hands, has done very well.
Okay, our friend Tom just texted, what is Parkinsonism? My mother had that, not the actual Parkinson's disease. Parkinsonism, is that the stroke thing?
No, Parkinsonism is part of, it's very similar to Parkinson's. It's just that you have some of the symptoms that look like it, but you actually don't have Parkinson's.
So there's no tremors in vascular Parkinsonism is the note that I have.
Correct.
And is one more serious than the other? I guess it depends on the patient, huh?
Yeah, Parkinsonism, 80% of people who have Parkinsonism have Parkinson's. And Parkinsonism is the motor side of that, right? Rigidity, tremors, and those are the things that we talked about with Parkinson's. Well, like I said, there's many different causes for those. Okay. 80% of Parkinsonism goes on and is actually Parkinson's. 20% has a different neurologic reason for it, but yet has the same symptoms as Parkinson's. Hopefully I didn't confuse you there.
No. Oh, I get confused easy. Or easily, if you want to speak English. One more texter?
Yeah, one more texter from 309. And this is interesting. We've heard about this a lot. Reheating your food in plastic containers. And I've heard get rid of those plastic containers and use ceramic or use glass. They want to know, is that truth or is that true or false?
Well, we're always looking at microwaving food and what's coming out, what's bleaching out of the containers that we are using. I mean, if you want to be safe, certainly use the ceramic. That would be the best way to go because you don't know what chemicals are being used, even in paper plates, the plastics that they put on those. I always think, that's just fine. When in fact, no, they've shown that leaching out of those are chemicals, some of those forever chemicals, which now you have ingested. So I would say if you want to be safe, the best way to do it is put it on a ceramic plate and heat your food and know that you're not going to get any of the chemicals that are embedded in any of the containers that we use.
And that's what you were just talking about that yesterday, Steve, with the
straws.
The straws, yeah, exactly. The paper straws.
Yeah, that the paper straw thing is not the be-all, end-all, and that there are problems related with that as well.
Yeah. Yeah, I mean, people, if you look at straws, look at the popularity right now of the metal straws. Now, they're a hassle to do, but individuals who are very in tune with their health or the environment because they're concerned about what happens to those straws and the damage they can do on animals, certainly a metal straw is probably the best way for you to go. But again, it's the hassle factor of carrying that around.
Well, and the metallic taste in your mouth and the cleaning it and all that. Yeah.
Yep.
And you chew on it and,
it hurts your fillings. Yeah, all of that.
We got to have you back to talk about RSV. There's some news there, but it's not as time sensitive as this is. International Overdose Awareness Day before we talk next time. Give me a minute on that.
Yeah, this week, Thursday actually, is like you just said, overdose awareness day. And we really need to start understanding to eliminate the stigma of drug overdoses. These are individuals who have an illness, they're sick, and they need treatment. So a couple things there. One is we don't have enough treatment facilities. If everyone who's using drugs right now said, I want to quit, we do not have enough treatment facilities. So obviously the awareness there. Two, the awareness of someone who early on is starting to abuse drugs, and getting them into treatment early is a lot better than getting them into treatment late. And then three, understanding that we have the ability to reverse many of these drugs using Narcan, whether it's fentanyl, heroin, codeine, opium, any of those. We know that Narcan works well, and Narcan now is over the counter and is available for free in many vending machines around many cities in many cities in the country. So really it's more about awareness right now of what's going on and how many deaths we're having that are needless deaths that we as individuals need to step up and say, I've identified somebody who needs help. Let's get them that help, or let's make sure we protect them until they get to a frame of mind where they're ready for help.
It's Dr. Kevin Most, and he is the best Senior Vice President, Medical Affairs, Chief Medical Officer, Northwestern Medicine, and the great people at Central DuPage Hospital. Please say hello and thank you to all of them, and we will talk to you later.
You got it. We'll talk soon, guys.
Thanks, Dr. Most.